we got one question around, can each speaker talk a little bit about how their current research projects are improving access to care? And I would start with Dr. Jordan here to talk a little bit more about the current projects and how they're increasing this access. So, Dr. Jordan.
Yeah, thanks so much. And I'll be brief to make sure that my co-panelists have a chance. But one of the projects that I'm really, really excited about is how we are improving access to medication for addiction treatment, right? So the type of research that we practice in the Jordan Wellness Collaborative is called community-based participatory research. And that means that there is not any research question that we interrogate unless we have representation from every single key stakeholder. So for us, it's Black and Latinx people who use drugs, Black and Latinx people with substance use disorders, community advocates, clinicians, and research scientists, right? All of them together. And so through that really discussion, we realized that we needed to partner with faith institutions to really meet people where they were in terms of decreasing stigma related to coming to an addiction clinic to get access, but also that we had to center not individualism, but people really wanted to get support from their community. So what we do in the Imani meaning faith, which was the name that was given by the community partners, is that we are studying evidence-based protocol that has been shown to decrease substance use amongst people with serious mental illness. And so these are modules that they take on a weekly basis. We talk about the impact of racism on substance use. We talk about how the social determinants of health impact substance use. And so they go through these classes, these evidence-based modules for 6 months. And during that time, if they are interested in actually starting medication for addiction treatment, for opioid use disorder, tobacco use disorder, or alcohol use disorder, we actually will see them in the church setting. And what is really interesting from what Dr. Mao said is that all of our addiction psychiatrists are actually from Black and Latinx backgrounds. So the participants are in the faith setting, but the psychiatrists are remote, but they're actually able to be paired with people who look like them, with people who speak their same language, and they're actually able to receive treatment and have inductions in a safe space. And we only do that if they opt into receiving medication. So if they don't want to receive medication, they can still participate in this evidence-based module that I was talking about. So it's really awesome. We've had over 808 people participate so far. So we know that if you build it, they will come in a way that's culturally informed. And we think that this is going to work better than referring people into the community for addiction treatment in clinics. And so that's the study, and we're going to see it, and invite me back to talk about the results. But that's one of the ways that we are increasing access to care.
Absolutely. Thanks for that, Dr. Jordan. Others on the panel that would like to weigh in on your current research projects that are analyzing, seeking to improve access to care?
There are too many, so I'll try not to talk too fast. But I will say, for example, that on Long Island with a multi-stakeholder coalition there, we are building what we would call a digital snapshot. It will be an app connected to an online registry that allows that person, and in the community we're trying to serve, people with IDD, especially they have communication challenges to begin with. They get worse when they're stressed, they're misunderstood, and then you intersect that with race, gender issues, it only gets bad from there. And the place the crucible where it is most dangerous for them is the emergency department. So this is a tool designed with the ED encounter in mind that will show that first responder, here's what I look like at baseline. See, I'm a whole human being who likes athletics. Here's are things that trigger my anxiety. Please don't do these to me. Here are ways to calm me down. I like listening to music. Click here for my tunes. But of course, this triggers one of our guiding principles, which is universal design. Really, one of the selling points we make to healthcare to address the needs of vulnerable populations, especially people who they think are weird, which is many people with CNS disorders, is that if you design a system for these people with the most significant need, you will end up with a better system for everyone. So we think, wow, I can't wait for this app. How fabulous for my 84-year-old Vietnamese speaking mother that would be, right? So that's one example. Another is that we are trying to develop a consensus health outcomes framework for people with IDD. And we begin with the IDD voices. And then we go to the family members and we say, you don't get to take anything away, but what would you add? Then we turn to clinicians and we say, you definitely don't get to take anything away, but how can you support these priority goals? And then we turn to payers and we say the same. And what we have seen happen throughout this process is that the light bulbs go off. And suddenly we have the payer saying, the clinicians want to get trained in communication strategies, we'll pay for that. And we're like, okay, this is being recorded. You know that, right? So I think that as people encounter the weird people and hear their voices in real time, it's very hard to not become invested in someone's well-being when you are breaking bread with them, so to speak, over this healthcare table. So some short-term wins, we hope, and some longer-term wins.
Thanks for that, Dr. Pham. Dr. Mao or Dr. Chang, any reaction?
Really excellent projects here. I'll try to be brief. There are two that I'm really excited about. So first of all, it's the matching algorithm, right? So if someone comes in and they say that they want a female therapist of a certain background, we can get that to them. I just wanted to flag something that's interesting here. So some of those things, some of the intuitive clinical suggestions make a lot of sense. So when they say, I want a female therapist, I've had trauma before, I want a female, and that actually results in better outcomes. But some of them actually are not true, right? So for example, what we found is when someone comes in and they say, I'm having questions about my gender identity, and I want to talk to someone who has LGBTI background, it actually isn't necessarily the case that that's actually what they want. So we actually track outcomes at the other side. The clinical outcomes is what really, really matters. So I just want to say that there's a lot of nuance here that we're still just beginning to unpack. In the same way that you don't ask all the time your patient in primary care, what meds do you suggest? What modalities would you suggest? There's a balance here to be had. So we want to be dictated by the data there. The second thing I'll just mention that I'm really excited about is that we have a crisis specialist program. So the idea here is that we can detect who's suicidal within our population with very, very high accuracy using machine learning. And the idea here is to be race blind about this, right? So based on the text message that they're sending us on a regular basis, we can detect now with 97% accuracy which patients have suicidal ideation. And then we can proactively call those patients within minutes. We don't wait. We don't say, hey, call 988, call 911, although we do send that message, but we proactively reach out. And what we found is that if you look at the ethnic breakdown and the backgrounds of those people, that's across the entire range, right? Whereas if you look at the data from 988 or 911, they tend to skew, for mental health specifically, they tend to skew white, Caucasian, right? Because that is a very tried and true modality for that population, right? So you can use machine learning for good here in order to democratize access to high quality care.
Yeah, really interesting, Dr. Mao. Thanks for that. And Dr. Chang, I know you all fund many research projects at the National Eye Institute. Any that you'd like to highlight here?
Carl, there's a lot that we're interested in this area. I'd probably highlight two things that we haven't, that I haven't heard as much in this discussion. One of them is the importance of diversifying the workforce. There are a lot of programs that we have in terms of early career awards or early career awards that are targeted toward, that are sort of emphasizing, trying to get more people from underrepresented backgrounds into the, in our case, vision workforce. And I think it's important to identify people when they're very young to build that pipeline. And one of the projects that we started last year was basically a video contest for high school students. And the idea is that you make a video about something that interests you, ideally about vision or vision science, but it doesn't have to be. And then, the winners would get cash prizes, and we brought them to NIH to spend the day in Bethesda, and they met the NIH director, met a lot of people here, and met scientists from a diversity of backgrounds. And I thought it was a great time. We're doing it again this year. Literally a week ago, we had a joint workshop with NIMHD, the National Institute of on Minority Health and Health Disparities. And it was a day-long workshop that took us, 6 months to plan together with them, where there were experts from, vision, population health, sociology, health disparities, community health, and disabilities, and other areas. And we really tried to get to this area of root causes and the best way to try to address these. And I really hope that this interdisciplinary view toward the problem is going to be what helps us, getting people together from these different perspectives, come up with the best solutions. And I'd like to be able to announce something tangible that's coming out of all this soon. But there's a lot that we're doing at Baseline. Baseline meaning within the past 2 years since I've been in this job. And the two things I mentioned are some of the things that we're literally working on right now.
Oh, that's great, Michael. Thanks for that. And looking forward to hearing more about that. Dr. Mayo, a couple of questions about Cerebral that I'm hoping that we can touch on quickly. How can we refer people to Cerebral, one, and what sorts of payment options do patients have to pay for services provided by Cerebral?
Yeah, great question. Thanks for that. So the easiest way is just go to cerebral.com and you can sign up. We try to keep the price points well below what cash pay would be for talk therapy or med management. And we do have tens of millions of lives covered in insurance, although we don't have all insurances covered. I will say, our mission is to democratize access to high quality mental health care for all. So we eventually want to get to Medicare and Medicaid in a value-based way. We're not quite there yet, but it's certainly something that we want to do. And the way that we can do that is by measuring clinical outcomes and being able to say, hey, for this high risk tranche of patients, we're able to decrease hospitalizations and emergency room visits. That's preventable. And as a result, we can work with the insurers to say, well, that's valuable to you, and we can get paid on value of care instead of volume of care.
Thanks, David. And what was that website again?
Sorry, cerebral.com, cerebral.com.
Okay, all right. Now, so I got another question that maybe is not as straightforward for the panel. How can we try to address health disparities or disparities in access to care as individuals, given how pervasive the origins of the disparities are in societal structures and not having a lot of power over those institutions, right? And so this one really gets at, this idea of how do you approach access to care and disparities, when there are entire regions of the U.S. That have obvious systemic barriers that aren't easily to overcome in a single person's career. What are your perspectives on that to the panel? Maybe I'll start with Dr. Jordan on that one.
Yeah, thanks for starting with me. But listen, I love the African proverb. If you want to go fast, go alone. If you want to go far, go together. And I really mean that and have really tried to practice. So I think the first thing is really thinking about how can you collaborate with people who are like-minded and really want to bring about change. You don't have to save the world, but you have to really be myopically focused on one project, starting in your own neighborhood and thinking about how you can create partnerships with people who are interested in addressing disparities. And so one of the ways that we really try to do that in our lab is focusing and really collaborating with nonprofit organizations that are sick of Black and Latinx people not receiving equitable care, and really trying to design health services research that address problems. And we're making some inroads there. So I think do not be discouraged, do not be overwhelmed, but really thinking about how do you leverage those collaborations for people who are like-minded and really myopically focused on one particular problem.
Yeah, I agree with you there, yeah. And I tell you, in partnership, it's not a one size fits all, but the magic happens when we put great minds together that include all sectors of the community to tackle some of these issues, and so that is the hope. Other perspectives from the panel.
Carl, I would add, in terms of that question, the question is phrased a little bit nihilistically, like there's nothing that we can do. But I would argue that a lot of the research that we see, comes from big academic centers. And not to pick on any individual centers, because this could be true for anyone, but I don't think Harvard and Stanford are representative of what is going on in this country. And in fact, that's one of the problems, that we don't have data about, in some cases, what's really happening in this country. And maybe we need more, we definitely need more research from, what I'd call real, community centers. And so I would suggest that this, the basis of this question really suggests that I hope that's empowering to people who are out in the so-called real world. That's exactly what, in a lot of cases, we're missing now.
Yeah, and I might add to that just really quickly. If you think about, I go back to what Ms. Quita Highsmith said earlier about trust. We are willing to give our data to Google and Facebook and Amazon to make our lives that much more convenient. If we can build that trust with healthcare, we can give that data and use that data so it can better predict when mental illnesses are coming on, when we need treatment, when we need adjustment in our meds. The limitation there is not the data, it's just building that trust and then gathering the data and analyzing the data, same as the big tech companies have.
So
absolutely, and I know Dr. Pham, you have an idea here.
Yeah, so I was just going to say, of course, IEC focuses on the IDD population, but we do have a pretty open door. All of our projects are heavily populated with community members. They are core team members, they are advisors, they're just regular people who want to make a difference. And then we have a separate initiative that we consider kind of our wraparound movement building initiative. We call it the IDD Advocate Corps, and it's targeted at people who are professionals in healthcare, various sectors. They can be researchers, clinicians, insurance executives, whatever. But we partner them on the team with people with IDD and family members. And that group is meant to become an army of insurgents, of change agents from within healthcare, who will tackle sector-specific goals for action and change within their communities, within their sectors, while coordinating amongst themselves and also with other advocacy networks. So there are lots of platforms out there for you to join in and lead if you so desire.
Absolutely. Thank you, Dr. Pham. We'll say a last word for Dr. Yasmin Hurd. Thank you so much for just a powerful panel discussion. And as Michael, you said, I think there is hope in the way that Dr. Jordan mentioned, in partnership and finding ways and considering new ideas and out of the box opportunities to get people the resources that they need. So I will pass it over. Thank you so much for your participation in the panel today, everyone. I'll pass it back to Dr. Hurd. Thank you so much.